Hello, everyone. Welcome to today's Tuesday topic. Today's topic is Atlas Paincare, an interprofessional framework or mentoring framework. While we're waiting for other folks to join us and for everybody's microphones to get tuned in, let me just plug a couple of upcoming Tuesday topics that we're doing this summer. Oh, welcome to summer. Our next Tuesday topic is going to be on the other side of the 4th of July holiday. It's Raising Our Hands with Jenna Arnold. And then a couple weeks after that, in August, we're going to do one called Just Show Up, about community engagement. And then later, the next week in August 17th, same story, different generation, each one, reach one in higher education. And then we're going to follow up or wrap up the summer quarter with Ethically Speaking, a case study on data management and acquisition. All right, so let me throw it over to Sarah Wenger, who is professor in physical therapy and rehab science. Sarah, introduce yourself, introduce the team. Thanks.
Hi, everyone. Some of you know me. Hi, students. My name is Sarah Wenger. I'm a professor in physical therapy and rehabilitation, and I work 2 days a week at 11th Street giving pro bono PT services. And we're going to be talking to you today about a project that we're doing called Atlas Paincare. But I'm going to let the other folks on the team kind of introduce themselves briefly, and then we will get right into it. So Rebecca, my esteemed colleague from 11th Street, would you like to go next?
Sure. What shall I say? I'm Rebecca Vlam. I used to work with Sarah at 11th Street doing lots of good stuff like outpatient therapy and behavioral health consultation integration. And I am currently at Widener University in the Center for Social Work, and I teach the master's students lots of good stuff like advanced practice and trauma work. And I still have the pleasure of working with the Sarahs and with Scott.
Scott, do you want to introduce yourself briefly?
Sure. Hi, everyone. I'm Scott Horowitz. I am assistant professor in the Department of Creative Arts Therapies here at CNHP. I am also director of field education for our 3 master's programs and have been involved with Power Over Pain and the Atlas, Power Over Pain for a few years now, and Atlas since its inception. So excited to share what we've been working on for the past few years. I'll pass it to Sarah T.
Hi, everyone. Thanks for being here today. My name is Sarah Tomaszewski. I'm an assistant clinical professor in the Department of Physical Therapy and Rehabilitation Sciences, and the other half of Team Sarah in the PT department. I am specializing in orthopedic physical therapy, but I have a special interest in treating chronic pain and treating patients with chronic pain. I work in our faculty practices in addition to teaching in our DPT program and mentoring orthopedic residents. And Atlas has a special place in my heart because I feel like it's something that I really could have used as a young early clinician, and that I could probably use it now. I kind of have it now, and I feel really lucky for that. And so we're really excited to be here today and to share with you some of our efforts towards bringing this change in to our professions. What I'll also say to you is that since we're a small enough group, if you have any questions, please feel free to unmute and just speak up. We are hoping to really have this be very engaging and informal, so please unmute and ask questions as needed. If you're not comfortable with that, or you have the unmute inertia, feel free to use the raise your hand function or put questions in the chat. I can moderate the chat as long as I'm not actively talking. And so Atlas Paincare is an interprofessional mentoring framework. This work came out of the Dean's Rapid Relevant Response Grant that helped us with really it was the impetus for us to really get moving on this and put it all together. And so just some background information. Sarah, if you want to go ahead and advance the slide. And so for those of you in the audience, whether your interest is in chronic pain or interprofessional education or both, there are gaps in applying both chronic pain care as it currently is recommended and also interprofessional collaboration when we actually get to clinical practice. And so whether or not you have a lot or a little of clinical experience, it shouldn't surprise you to know that chronic pain is a very common problem. And so with the advent of the naming of the opioid epidemic, from a national level, recommendations have changed for the treatment of chronic pain. And so this goes back to a National Academy of Medicine report that calls for wider use of our existing knowledge, improved individualized pain care, and really emphasis on self-management. This goes along with a focus away from opioid treatment of chronic pain and a movement towards non-pharmacological therapies, really with a focus less on getting rid of the pain and totally eliminating it, and really in changing the focus, shifting it to teaching people how to manage it and to improve their quality of life, even with the presence of chronic pain. And so the recommendations are that patient education, interdisciplinary teams, interprofessional care involving both behavioral and physical activity modifications, and psychological therapies are all sort of recommended. And so this is probably not a surprise to anybody. When we work together, patients get better faster. And that is really required for the treatment of chronic pain. Unfortunately, there are just so many barriers to actually putting this into practice. And so as clinicians and educators, we've experienced a lot of these barriers, whether it's inadequate time, inadequate training, systemic barriers like reimbursement. There's plenty of continuing education. I know definitely in the chronic, in the PT world, I would probably say confidently that this is true, and also for our mental health colleagues. There's an abundance of patient education and clinician education, but really a lack of connecting the dots and really mentoring people to work in interprofessional teams. Interprofessional education is a huge buzzword right now in the health professions and in the medical field. And everybody says they want it, and they say that they do it, and they say that we're treating people to do it. But when we get out into the clinic, as many of you know, actually putting those skills into practice in a productive and efficient and effective way is really, really challenging. And so one of the things we've identified as a gap is mentorship in providing interprofessional chronic pain care, both in the mentoring piece of it and also in the actual chronic pain knowledge. Go ahead, Sarah, next slide. I think you're up.
Yeah. So I'm going to talk a little bit about how, and we're going to go way back in time to 2011 now and talk about how this work kind of got started. So at 11th Street, Rebecca and I were working at 11th Street, and this is 2011. One of the physicians nearby passed away, and his patients, we were the next closest primary care office, and his patients many of his patients started coming to see us at 11th Street. And he was basically just a pill mill. He was prescribing opioids for everybody with chronic pain with little to no other treatment. And, he was just giving people opioids and basically nothing else. And so people were coming in to 11th Street expecting a Percocet prescription. And what we normally did at 11th Street is when patients presented, particularly patients we were unfamiliar with, when they presented asking for opioids, the nurse practitioners would send them to physical therapy so that I could do an evaluation and sort of determine, does this patient need opioids? Can their pain be addressed by other mechanisms? Should we send to a specialist? Should we order imaging? Are there other medications? How likely are they to respond to conservative care? These kinds of things. And so I was getting a parade of people coming into my office. And when I asked them why they were there, they would say, I'm here for my Percocet prescription. And, I'd be like, I don't think you really kind of grasp the whole way we work here. But suffice it to say, it was challenging because those patients were scared. Their primary care doctor died, and now here we were wanting to change the way that their pain had been managed, sometimes for up to 20 years. It's like several years to many, many, many years and decades. And so it was quite challenging, and they were patients that needed a lot of time and education and coordination. And we already had a model at 11th Street for what we called centering for pregnancy, where pregnant women basically would come in once a week and just do all the things that they needed to do in that one day, educate, see all the different providers. And so we decided to start a centering for chronic pain program. And that's how we ended up developing Power Over Pain. So I waltzed over to Rebecca and one of the nurses we worked with at the time, and we said we should start this. So that's what we did. And our goal basically was to, coordinate care better, both so that it would work better for patients, but also so that it would decrease the burden on individual providers. And we all sort of felt like we were drowning individually without a team and needed more support to engage, educate, and empower patients, obviously to provide high quality evidence-based care, to provide trauma-informed care, which is always a goal of ours at 11th Street. So to keep that going throughout this group, to help patients build resilience, and particularly resilience, because our goal is going to be to taper opioid use, not necessarily completely, but to certainly reduce opioid use and reliance. And so building resilience in the face of making those changes. So we developed this clinical reasoning model, which is basically what we based the program on. So you can see at the top of the model, there's this sun-shaped thing called the self-managing patient. So with chronic pain, or really with any chronic illness, right, the goal is going to be getting, I always say, if you're not going to get somebody 100% better, you better be teaching them how to take care of themselves. So really getting it so that patients can manage as best they can on their own. And as healthcare providers, we're serving more as a consulting team instead of this sort of top-down director type role. In the middle of the diagrams is this interprofessional team. So who are all the people that need to be involved to address chronic pain? And we know chronic pain is multi-system and multifactorial and multifaceted. So we need a good interprofessional team for that. And just to point out that the patient is included on this team, and that the team is engaged in really unified reasoning, a unified plan of care. So instead of the patient seeing me in PT and going to see Rebecca for social work and going to see their primary care provider and getting different pieces of education and different plans of care and really not knowing how they all fit together and how to prioritize, that we as the team are sort of getting together, figuring out what the priorities are, making our goals align and our treatments align so that it seems like one cohesive treatment plan for the patient, and they're not having to, we're the professionals are sorting that out for them instead of making them do it. And then these pillars at the bottom are sort of all the different areas of evidence we felt like we needed to use to base our decision-making on. So I am going to turn it over to Rebecca to sort of talk about how Power Over Pain went at 11th Street.
Yeah, so, I unmuted myself. So I just want to add that we weren't just coming in with the Percocet need. They were often prescribed both Percocet and a benzo of some sort. Everybody was on Percocet and a benzo. And so the idea of being responsible about what would happen to their bodies if they just didn't get their prescriptions after 10, 20 years of taking it was nerve-wracking. And that was another sort of catalyst for, we need to do something together. So we worked with this wonderful nurse and started a Power Over Pain group that was a little slow starting. And then when we realized if we provided lunch-ish items, we got a lot more people there. And we wound up keeping them for a really, really long time. So we would get together, we would do, each week there would be psychoeducation with handouts and take-home work. There was a lot of discussion. There was problem solving, and what we noticed, as most good groups do, is Sarah and I and Nurse Pam could kind of back up, and the group kind of took care of each other. and really sort of processed stuff out together and became problem solvers together. And we truly walked alongside people, pointing out the different scenery as opposed to leading people. What am I missing?
I think we did develop all of these handouts, and so we developed a curriculum. We spent some time thinking about what the curriculum should be, and we would give like a brief introduction to the topic that was usually no more than 10 minutes, and then it was really discussion based, as Rebecca was saying. We really let patients kind of talk among themselves and lead each other, and it was very sort of an equal discussion based group, not a lecture at group, not a lecture and listen group. So there was a lot of idea sharing and social support, and sort of dealing with people's barriers. So not just saying, hey, you should do this, but like, how did it go when you tried to do that? What kind of barriers did you run into? Like, let's problem solve as a group together. And then Rebecca was present at every session just to make sure that we like kind of kept it healthy for everybody. So it was out of doing that work for the last 10 years. And as we were doing that, we were thinking, well, as T was talking about in the beginning, like there's a lot out there. There's a lot of other groups sort of similar to Power Over Pain out there. Like we don't necessarily need to replicate Power Over Pain all over the world. But what we really felt like was that people who wanted to do things in the clinic would have like an idea of what they wanted to do. They would want to do whatever their version of Power Over Pain or whatever their version of chronic pain care was going to be. And they'd go and try to do it. And it just kind of wouldn't work. We were getting a lot of feedback. Like, I know what I want to do, but then when I go try to do it, it doesn't, I'm not successful. And so that's where we came up with this idea to do some mentoring. So I'll turn it back to you, Rebecca, to, let me see, yes, introduce our Atlas idea.
You know what, I just wanted to add there really quickly that one of the really wonderful things that came out of that, even though we had been doing interdisciplinary care to begin with at 11th Street, I think this was the first group that was interdisciplinary led or given, right? So there were different disciplines in this group. We did not have to report back to each other about things. We were able to sort of brainstorm together, and people, I think, felt like they were really cared for in a very holistic, truly holistic way. Yeah, and so Sarah really, like, Atlas came out of this, or Power Over Pain became Atlas after a while. And so we decided, wow, we should take this on the road. This is amazing. People get better, faster, and with more support when all of their primary care providers are working together. All of the disciplines that they work with are working together. And so this is a mentorship program. I don't want to read the slide, but helping to design all of the teams, develop their own picture for their practice using multiple disciplines. Things are always patient-centered or person-centered, as the social worker might say, and that this is all about self-care, decreasing the need for opiates, and increasing other ways of healing, and also understanding that sometimes we're in pain, and there are different levels of pain, and there are different ways of living with pain as well. And so the Atlas platform provides the tools, provides the knowledge, has the support, shows you how to have an interdisciplinary team, how to provide best practices. And then, I don't know, Scott, do you want to jump in and talk a little more about this?
Yeah, sure. And we had a little kind of transition phase of taking what Power Over Pain was at 11th Street, and kind of boiling it down a bit to a shorter time frame and really time delimited program that we then ran at what was Parkway Health and Wellness at Drexel at CNHP. And I think the experiences at 11th Street really brought to light for everybody who was involved there, the power of the interprofessional team and the need for understanding each other's roles and responsibilities and kind of leaning on each other in the way a good team does. So while both of the Sarahs working in PT have a ton of knowledge and awareness around mental health needs of their patients and attend to them in their practice, in their particular style of practice in PT, it was clear to them from their work with Rebecca that it was really important to have somebody as part of the team that really understood group process from a therapy standpoint and how to help structure and provide support within the group so that they could bring their expertise in the physical therapy side of things and not have to necessarily be attending to those things that weren't their expertise. So when we brought over to Parkway, they came to me and one of our colleagues in the couple and family therapy department and said, we'd love to have you all involved in running this program. And we pulled in from physician's assistant department as well. And so through that experience too, I learned more about physician's assistants, and we brought in different people on different weeks, nutrition. So it was like recognizing what we knew and that we all knew some things beyond the scope of our own area of practice, but why try? And this is what happens often. We try to then do more than we're really skilled at doing. And usually that's out of necessity. But when you have the ability to come together in an interprofessional team and rely on the people who really are trained in that area, who that is their scope of practice and they know what they're doing, then you can lean on each other and play to your own strengths as well in terms of doing it. So as we then moved from that experience of coming together and creating it, and I think that next round of experiencing what it was like to form a new team. So it wasn't the same team at 11th Street. It was going through a process of forming a new interprofessional team, learning how to become a team and work together, and feeling like we were relatively effective in doing so. The feedback from the participants in the group told us that. It wasn't our own sense of self, but the participants who really gave us feedback on how we were as a team and how they felt supported, how they felt like we gave them space to interact with one another, led us to feel like, okay, as was shared earlier, okay, maybe we have something to offer beyond our walls of how to come together, function, build the team, build the knowledge and awareness. And that was part of it too. For me, my background's in music therapy and professional counseling, but pain care and chronic pain care was not my area of large practice and expertise. So for me, going through the process, and we didn't do our full Atlas model as it lives today, but we did some shared learning, and I certainly did some learning through reading and talking with each other, so that I felt like I had the tools for the pain science knowledge base and the support we needed to be able to run the program. And so that really all kind of, again, led us to say, all right, there's something here. There's something that we can build upon, and we just need to kind of, give some structure to what it is that we've already been doing. And I think if we do that, then we can share that out with others and it would be useful to others. So that was sort of the evolution to the Atlas Pain Care program developing. And then we started to flesh it out.
T, our queen of structure, take over.
I wear that tiara proudly. Somebody has to balance you out. And so our framework has 5 stages, and the stages were really our attempt to articulate what we needed to do to take this thing that we had in Power Over Pain and try to package it in a way that we could go wide with it. And so, as I mentioned earlier, there's so many barriers to successful interprofessional care. And what I think, what is easy to take for granted, starting with Power Over Pain at the 11th Street Family Health Services, is that it is an interdisciplinary practice that is pro bono. And so that gives clinicians a good deal of flexibility that you don't necessarily see out in the typical outpatient practice, at least for physical therapy. As physical therapists, and I think my colleagues would agree, even in other healthcare areas, we often practice in silos, right? A patient comes in with a referral from their doctor, and you do your thing that you know. And if you're trying to make any attempt at interprofessional care, it's not usually billable time, right? So it's on your time outside of your schedule, or it's an additional burden on the patient to try to get them to communicate with their other providers. And so this preparation stage really speaks to that, because the first and one of the biggest barriers, I think, is actually creating your interprofessional team. We experienced this even with the transition from power over pain from the 11th Street practice to the Parkway Health and Wellness practice, where even though both are well, Parkway Health and Wellness is no longer in service, but at the time both were interprofessional practices. In the pro bono setting, there's a little bit more flexibility in terms of what you're able to offer in people's time. If you're in a fee-for-service setting, it's really challenging to get around this idea of billable time. And so we're fortunate to have the support of our administration to set up a payment structure. But we encountered right away, even though we're the ones making this thing, that there are some really big systemic barriers in place to doing this in the first place. And so the preparation stage, and I'm actually, Sarah, go ahead and skip to the next slide. So all these stages are outlined on this next slide that fleshes it out a little bit more. And so I think this is a little bit better way to sort of look at it. So this preparation stage is intended to help create your team. And so whether that's in our project, what we did was we had folks reach out to us. We actively recruited some interested clinicians that we knew had interprofessional connections, whether that was in their clinical practice or in their health system. And so they came to us with some teams intact. I know one of our big reach goals is to try to set up some sort of infrastructure where people can find a team, much in the same way that you searching for a doctor might look for a provider. We would hope, we someday would like to have an ability to, search for your chronic care team, assemble your Avengers and get them all together. And so the Atlas platform is currently in development. We have through our own self-study, built some things using Slack. For those of you familiar with that platform, we have an Atlas Paincare platform that is currently in development that is a bit fancier Slack, for lack of a better technological description. And so this idea would be that you would be able to create your account, designate a coordinator to communicate with the Atlas mentoring team. And the Atlas mentoring team would consist of both clinical mentors, of which Sarah, Rebecca, Scott, and I are the original members. And then we also have research mentors to be able to help with collecting outcomes, both clinical outcomes, potentially financial outcomes, to be able to help our participant teams build their team, not only build their team, but also show to the money crunchers that it's effective, right? So these are all the things that we know about interprofessional care. There's evidence that supports them, but there's this disconnect between the evidence that supports what's the right thing to do and the people who are paying the bills. And so, we're needing to, our plan is to build in some infrastructure to the mentoring program to be able to help our teams receiving the mentoring be able to show the powers that be that this is not only a thing that works in terms of reducing costs, but also improving outcomes. And so we're sort of beginning with the end in mind there. And so once the teams are assembled, stage 2 is the journal club. And so journal club serves as essentially the training, if you will. We don't call it a training because it's really more of, it's more nuanced than that. And so it's a structured journal club that has built-in questions for reflection. The journal club information itself comes from all sorts of bodies of knowledge. We were very, very intentional about not being discipline specific because, again, we're trying to create an interprofessional team. And so if I want to learn about psychologically informed care for physical therapy, I probably shouldn't go to the PT literature, right? I need to branch out from that and look at some more diverse sources of information. In addition to the journal club articles that we've curated, what we've also done is built in some infrastructure for team building, so that as you're going through the articles, there's questions for reflection, not only about the content, but about how you engage in this interaction with the content with your team. So that as you're going through the educational information, you're not just learning new things to try and practice, which is, awesome in and of itself, but what you're also doing is you're laying the groundwork, you're laying the scaffolding for what your eventual pain care program will be. And so you're doing this in tandem as you learn about the different materials. And so once you go through the journal club, then there's a touch point with the clinical mentoring team to really, nail out the details of what your interprofessional pain program is going to look like. For those of you detailed-oriented types in the group, you'll notice that this is intentionally really vague and gives ranges of dates here, right? And so given that one of the barriers for successful interprofessional care is time, we wanted to make this as flexible as possible for participant groups to be able to do it in a way that works for them, that's sustainable, right? Making changes to your clinical practice is like any other behavior change, right? And so if you're past pre-contemplation and you're making a change, we want to give people time to be successful with this. And so that's why this isn't necessarily very rigid in terms of how the program is set up. And so stage 3 is really nailing out the details of your program based on the scaffolding that you laid out in your journal club. And so then the implementation stage is where the clinical mentoring, I think, really is intended to shine. Because again, we've provided this really well-rounded continuing education through the journal club on creating an interprofessional pain program. We've hopefully mentored the teams into building some sort of structure that's going to work for them, recognizing that just because Power Over Pain worked for us doesn't necessarily mean that everybody's group will look like Power Over Pain. It may look totally different than that. So regardless of how it looks, our intention is that we want to be there alongside the participant teams as they build their program, because this is really where the mentoring takes place, right? I think those of you in the crowd, if as clinicians, right, if you are, starting your practice, even if you are a newly licensed professional, it's important to have mentorship structures built in. And so, I don't think I need to sell the idea of mentorship to everybody, but this is, I think, where our program is unique in that we're, going along with our teams to really help them work out the details and work out the kinks as it happens. And then concurrently, stage 5 is really looking at outcomes and refining the program. So not only identifying some easy outcome data points to be able to collect, whether that's number of visits, whether that's pain scores, whether that's other patient-reported outcome measures, and then trying to look at costs. I think that's a big outcome measure that we're really looking to help track with people, recognizing that, money makes a lot of decisions in healthcare. The more we can, I think, show that this is more efficient in helping people get better results and lower utilization, saves patients and clinics money, that's an outcome that we're really interested in looking at. And then helping folks develop their next steps, whether that's, growing their program, whether that's, taking our teams and then, training them to be mentors so that they can now join us as Atlas program mentors. And so that's really the long and the short of it there, more on the long side. Go ahead, Sarah.
Yeah, and I'll just add that, we really felt like it was important to be flexible. So we're not saying, here's a program, registered, copyrighted, whatever, and this is step 1, this is step 2, you're going to plug and chug and do this thing we described, but really really take a mentoring approach and help people develop something that works for their patients, their community, that accounts for their resources and their strong points, that's really individualized to them. And we felt like that was that's more effective for patient care, that it would also be more effective for program development.
Sarah, I'll add in too, we also wanted that flexibility to be able to this be applicable for all different types of settings. So not just those that are well-resourced and have the money to put behind it, but those that are under-resourced and serving often underserved populations, and making sure that this was accessible across the board.
Yes, that's actually our special population. That's really where we're focused, is on underserved populations. But we did want to make something that was accessible for everyone, in different settings across healthcare too, like whether it's a hospital or outpatient based or whatever. So what we did, we collected feedback in two different ways. As part of the grant, what we did as we got teams together, interprofessional teams together, and we sort of took them through what we had planned and a little like sort of skeleton of what the website would look like or what the platform would look like, and sort of explained what we had in mind. And then we did focus groups and asked them for feedback. So that's essentially what we did there. And so we collected the feedback from the focus groups and analyzed that for themes. What we also did, this was not part of the grant, but the Interprofessional Journal Club is something that we've done as final projects among different groups of students. So our physical therapy students have done this with art therapy students and also with social work students. And for several years now, the Journal Club has basically been the chronic pain module for orthopedic residents. So that wasn't interprofessional, but those students were going through the Journal Club and doing discussions with the two residents and me. So we also have some feedback from students about just specifically that stage 2 and what the Journal Club was like.
Can I add something right in there about the Journal Club?
Yes.
The Journal Club sort of mimicked what we were trying to do with this whole idea, in that because we had these very different students from very different places, what we determined, and I was at every Journal Club meeting and discussion, what we found is that there would be pieces missing that we would notice, right? So we had a lot of stuff on pain, and we had a lot of stuff on psychology, mostly behavioral stuff. We had a lot of stuff on PT. We didn't have a lot of stuff on trauma. And that's the number one thing we should have stuff on, right? So throughout all of these discussions in these journal clubs, we sort of mimicked the whole idea of Atlas in the first place, and we're able to find those spaces that things were just sort of slipping through. And it was a wonderful experience.
And Rebecca, you can just keep on going with affirmations and areas for improvement from our data.
Oh, well, so the folks that did this with us found that we needed a physician involved, and we needed administrative roles on the.
Can I just interrupt for 1 sec? So the affirmations, we organized the data based on, like, of the feedback we got, what affirmed basically the plans that we already had, what affirmed the things that, the gaps that we found ourselves, or the things that we felt like we needed. And then the next slide is going to be suggestions for improvement that we hadn't considered from the data. So
right,
sorry about that.
Right, I apologize. These were the things that we already knew, but were sort of confirmed that we needed a physician, we needed administrative roles. Everybody needs administrative roles. It's just finding the money to pay for that. We needed a mechanism to be able to share information. We needed a well-designed platform to be able to communicate with each other, to organize and to communicate information. Mentoring was important. Again, fiscal and administrative support is needed. Interprofessional perspectives. As I mentioned with the Journal Club, we just learn from each other constantly. And while we don't pretend we can be each other, we're able to integrate that knowledge and I think really approach the folks we work with greater understanding and more humility and more curiosity. The expertise of mentors is huge. And one of the things that we talked about with this program is that we wanted a pay it forward program. We wanted to initially be the mentors to the new folks, and then have new folks get really good at this and become mentors to other folks. And we wanted this to spread. And probably a year and a half ago, I would have used a term like a disease, but now I'm not going to, because it's just been too dramatic. And we knew that interweaving learning and mentor feedback is beneficial, and discussion-based learning is absolutely invaluable. Just learning by talking with each other was fabulous.
And areas for improvement.
You go.
Okay. So our areas for improvement were that there was a lot of feedback about reducing the time demands, particularly the time demands of the journal club. I'm not going to say that was totally a surprise for us, but if we either reducing the demands or really making sure that people had time for it, that there was some kind of way of carving that out. To provide a little bit more clarity about team roles. Some of the feedback we got was that people wanted like a better sense of what the different team members would be responsible for. Incorporating patient voices more overtly, so maybe bringing in patients as part of the planning process, which we had not explicitly included as like part of the instructions. And then enhancing interprofessional resources. I think that there was just a ton of feedback about wanting resources, wanting mentorship, like having a place to go to find each other and find information and make connections. And there was just a ton of feedback around that. And then just like the volume of information that one needs to know to do interprofessional work, like knowing about all the different professions and knowing about chronic pain and all the different systems that chronic pain impacts and the the whole biopsychosocial holistic, it's a lot of information. So just appreciating how overwhelming that can be, and making sure that there's sufficient time to prepare and implement for that. Go ahead, Scott.
I'll say that these suggested improvements were actually also very affirming for us as a team and validating, because they were the things that we wanted to do. They were already kind of in the pipeline as the next steps. So it was good to see that we are heading in the right direction and are going to be able to make the improvements to meet the need. And there weren't things that totally came out of left field, which would have been welcome as well, of course, because we all have blind spots. But it was actually very, very affirming to see that the things that could be improved were things that were already intended.
So T.
And so with this, our next step is really to do Atlas, right? To do the thing. And so our goal for that is to apply for an implementation grant to get some financial support for this, to help support us as, this is not exactly part of our day job as faculty here at Drexel. And so getting some support to do that. Adding physician administrative team members, again, from our list of affirmations, this is something that is presently on our list. We're looking for the right person. If you know anybody, if you are a physician or work in administration and are interested in joining the Atlas team, please talk to us. Especially recognizing that, all of the improvements, many of the improvements were around this idea of time, right? And so I'm not sure that our direction would necessarily be to reduce the amount of information, because you need all of this information to be successful. But what you need to do is empower people to have the time and the headspace to do the education that's necessary. And so it really became very obvious to us that getting these team members on board and as part of the development of Atlas is really necessary. Additionally, we need to further flesh out our technology development, and so really make sure, one of the strengths that we heard in our feedback was that the information that was from the technology platform in development was much easier to understand and much easier to follow than the information that we were presenting to the focus groups. And so it just reinforced the importance of a really well-structured and intuitive technology platform. This will additionally help us, as I said, provide mentor support in getting the teams going, and also hopefully, and this goes along with our goal and value of wanting to serve the underserved, be able to provide some financial incentives for clinical sites if they sign on to do the program, to be able to support buying out their time and provide financial support to clinical practices who do want to implement the Atlas programs as we're getting started. And so this is our reach thing, the big thing that we have to do. In the meantime, as faculty, we're constantly thinking of teaching and mentoring. And so we thought also a great way to keep Atlas forward momentum going would be to create an interprofessional chronic pain module for CNHP. And so to be able to provide interprofessional education to current students or to I believe local clinicians. I'm not totally, Sarah, you can jump in on this if you need to, because I'm not sure our mechanics of how we're doing this, but I think it really is another way that we can, sort of create our own future with this. If we're laying the groundwork for our health profession students while they are here working with us, then certainly that gives us ongoing forward momentum to not only spread the influence of the program, but also to help more patients, right? If we can start here, then we can have that exponential effect, I think. And Sarah, if you want to expand on that, please.
Sure. I think what we're thinking is to help us develop, because, when you go to apply for a grant, you need all your I's dotted and T's crossed. And we are process-oriented people. And so we would like to be able to start an interprofessional, chronic pain module of some kind at CNHP. We would love to be able for it to be interprofessional, but also with students and practicing clinicians, whether, there are probably 1,000 administrative barriers to this, but this is our dream. And, so maybe offering some kind of certificate or something for that both students and clinicians could get, or, we are not sure what's going to be possible within the structure of CNHP, but that would allow us to do that, do a couple of rounds of working on that and really refine what we want the program to look like and give us a chance to, process it out a little bit before, and also collect a little bit more information before applying for a grant. Because if we're really going to pay sites to do this, we'll be asking for quite a lot of money. So we probably need a little more data than we have right now. So I just want to say thanks to our clinical team, our research team on the grant, and to all of our participants, all of our Power Over Pain patients, everyone at 11th Street, and CNHP for giving us the grant, and to Giant Sky, who has been helping us develop the platform, but also forcing us to think in different ways, like really being a part of our interprofessional team and really coming at it from a different perspective. That's been really helpful. Here's some references, and I'm going to stop sharing so we can do questions and see each other. So we are happy to have thoughts, questions, whatever, discussion, feedback. Yes, go for it.
Hi, thank you all. I mean, this is amazing, and carving new paths is always exciting to learn from. I wanted to share a little bit about my work and kind of seek your advice in not really exactly related field, but very much interprofessional work that I'm also excited to be engaged in. So I'm very interested in working in burn care and burn research, and I'm an art therapist, so that's the path that I'm taking for now. And the 2 points that really drove home to me was time management, and in terms of time demands, and also discussion-based learning. I mean, there is no doubt at all that so much of learning for me also for the Burn Center happens in these discussions. But what I'd like to seek some advice was on whether you were able to identify what motivated the multidisciplinary team to, kind of bring to the table their own time and efforts. Was there a certain time of the day that you recognized as a team that worked more? Sort of thinking of because I'm as an outsider, I don't want to overstep, medical professionals' boundaries and time demands, but at the same time, sort of move towards this holistic work that they are also interested in, and kind of bring it to the center. So most of the burn patients in the inpatient are do suffer from acute pain, but that tends to be chronic over time. So there are some, kind of overlaps with pain. And again, there's very less research on wound-induced pain and everything. So just a little bit more advice on what really brings the team together. If that, I don't know if I articulated my question as much as I could. Yeah.
Well, I can speak. Oh, go ahead, Scott.
It's a good question. I think, I'll start us off by saying I think part of it can happen kind of institutionally. It can happen in different ways. I think you can have the institutional support where the institution is creating space and creating time and encouraging it. Often, though, that's not the case. Often, they're just fine with the siloed work as it exists. So I think the often more successful way has to happen then on the individual kind of interpersonal level of getting to know colleagues, getting them to know you. I know you mentioned as an art therapist, I know as a music therapist and creative arts therapist, sometimes it's a matter of first getting people to understand what we do and who we are and all that we have to offer. So that's happened, for me, through just getting to know people, talking, having the one-on-one conversations, and then from there beginning to kind of cultivate your team. And you kind of get to choose in that way the people that you want to work with, the people that are on board with Interprofessional, have respect for other disciplines, are willing to collaborate. And so I think, to me, that's a lot of what was successful about our group. Some of that happened at 11th Street, out of their natural work. The one thing I didn't mention about our transition over to doing it within CNHP was part of it was connected to a committee we had at the time for interprofessional education and research and practice. And I was at the time co-chairing that committee. Darren, who's here with us, was a part of that work, and Sarah W. was on that committee as well. And so through that committee work, we all got to know each other and said, hey, that was sort of where Sarah pulled me in from, actually. So just getting to know those around you and finding like-minded people who want to collaborate. Because in those early stages, if it's not supported by the institution, then you are giving of your time a little bit. You're kind of doing it outside the hours. And so you got to have that initial commitment to hopefully then pull that team together that can then say, hey, we need the time and space to do this effectively. Please, recognize what we're doing and the value of it.
I'm all about taking the sneaky route. I would get together 2 colleagues who you like working with and come up with a group that you want to do together. 2 colleagues from different disciplines, right? And come up with a group you want to do together and start off by just doing this group, right? That focuses on this one thing from all aspects of all the disciplines that you're working with. See what comes out of it. What we had is we had such an amazing response to this one group that it just blew up into something else, right? And then once you sort of have that data, so to speak, you can go to a supervisor or administrator and say, hey, look, this works, and here are the reasons this work, right? And then I think once people start seeing how the teamwork kind of gels and how much clients, patients, participants really enjoy this and it's beneficial for them, they're going to want to do more of it.
And is there a certain approach you had with communication with the interdisciplinary team?
We did. We had worked with each other for a while, so we did already have rapport. And I would say both of these groups started with people that already had rapport together, and that certainly helped. But I think we also, when we did Power Over Pain, we had 1 day a week where we basically did patient rounds. So we could sort of had a little bit of planning time outside of the class to coordinate care. And I would say that the motivation for me as an individual clinician starting this, we did have some support at 11th Street. And, we were given some time that we were allowed to spend some time doing it. But really, I had patients that I felt like I wasn't fully helping. right? I mean, they're coming in, they've got more problems than I can possibly solve on my plate by myself. And so I was like, I need people with me. And so really the idea was, well, instead of me spending like an hour of one-on-one time that I can never find in the clinic, only to also not meet my goals because the patient needs so much more than that. Like this was a relief for me, to be able to work as this team and feel like I was actually helping patients. So to me, it saved time. Like I was spending an hour with 5 patients with all people there to help me and getting way more done than I would have done in an hour with each of those 5 patients individually. So for me, it was very much a time saver and very efficient. Now, would the bead encounters have considered it that way? Probably not. And I think our focus with Atlas is to really get a good administrative member who really can, carve out the time. And I also feel like, you know how it is if you're like some lowly clinician at a hospital and you're like, I want to start this group, the hospital administrators are like, yeah, I know what you're doing, versus like, oh, we have Atlas Paincare. We want to do like just sticking a name on it and making it a thing and doing the consulting thing all of a sudden gives it a little more weight and makes it like we have this thing that's kind of already made that we want to do. And I think that that's easier to make happen. So we're trying to work that angle too in terms of Atlas.
We would also debrief. So meet before and then we would debrief after and then have sort of a game plan for next week as well. And we did it. I mean, we're all really, really busy with quotas and expectations and people waiting, right? And people waiting. And we did it. And if we had to talk on a Saturday initially, we would talk on a Saturday, which is not the most fun thing in the world, but we did what we needed to do to make it happen. And I agree with what's in the chat. Buy-in is totally necessary. And if you don't have buy-in, especially from the PCPs who, are the kings and queens of the world, it makes it really, really, really challenging. But I think so. And here's where the buy-in came. The buy-in came was because when this primary care provider died and we got hundreds of patients asking for appointments and wanting opiates and wanting their Xanax, right? The primary care providers were very much like, please come help anyone. I'll take anyone, right? And so when finding them in sort of a desperate need, even without that sob story, right? Even without that mess, if you start working with your primary care providers, offering help and support for more challenging patients with more challenging problems, I think they begin to see where collaboration happens. And it's tiny baby steps. It does not happen overnight.
Yeah, and I was about to put this in the chat in response to Christopher because I agree the buy-in is necessary, and also recognize that our hope is that we're not out here on an island, that what we're doing is part of a bigger trend in healthcare towards collaborative practice and interprofessional care. And there's a lot of organizations like Robert Wood Johnson, the Macy's Foundation, putting money behind research and clinical programs and grants to support interprofessional care. So that's another avenue too, is to go out and seek one of those initial, smaller level funding sources to then come to your institution and say, hey, this is really a trend in healthcare. We're behind the times. We need to get with it. And I've gotten this money for us to be able to do a pilot program here. But I truly believe it is the future of healthcare. There's plenty of evidence now to show patient-centered, interprofessional collaborative practice is the best form of healthcare. And our country has a lot of things that need to be fixed in our healthcare system. So I hope that interprofessional care can be one of those things that begins to be more widely accepted and honored, and that we're a part of that bigger trend.
Yeah, I just wanted to add to Madeline's comment and thank you all for sharing this wonderful program with us. It'd be great for students to get exposure to this type of interdisciplinary healthcare team like approach to providing care. So I was just wondering what the feasibility is of maybe including this as like embedding this into as like a clinical experience or like an ICE or would maybe just a volunteer basis work best for this program?
Well, it is a final project right now for PT students. We are really trying to get Rebecca and Scott's students involved, but it's just logistically being difficult. But you can still sign up for the Atlas Paincare instead of the Human Experience course if you're a PT student.
Great.
And I would say we're continuing to explore different, there's one sort of way it's looked for student involvement, and we're continuing to explore different ways. We have had some other interprofessional learning opportunities within sim lab experiences, working some with nursing. And so we are one, but there are some others, and hopefully continue to cultivate more and more interprofessional student opportunities at CNHP. So keep an eye out for like emails and invitations. If you see IPE on something, that's an opportunity.
Great. Thank you.
Hey, Kim.
Hi. I just graduated from Drexel from the DHSC program. I'm a physical therapist, and I live up here in Maine, and I work at Hudson University. And I also run the pro bono clinic, which has been kind of on a hiatus because of the whole COVID thing, but hopefully this fall we're back up and running. So the problem I'm having is all of my research is in autoimmune disease and self-management. So, we go through the pain and the fatigue and all of that. And I've done a couple of groups now, self-management groups. And so when I'm trying to get to the point where now we can pull other professions into it, because we have OT, we have pharmacy, we have nursing, we have counseling. So we have a lot of very appropriate type, that would work well in a team. But I don't know if it comes back to the buy-in and the time, and I'm having a hard time trying to pull people in. And I know this question was asked by somebody else a minute ago, but I have a space. We have a clinic that we've been using for a couple of years now. We have a very nice clinic. But I'm just having a terrible time trying to get the buy-in. And, I have the research, and I don't have a grant yet. So I don't know if that would be the next way to go. What do you recommend for just trying? Yeah.
I'm going to echo what Rebecca was saying, that we have sort of taken it to build it and they will come kind of approach. Like, I think this is where like a little extroverting goes a long way. Like, go find people, talk to them, be like, hey, I like working with you. You think the same, you would be into this. You would be great here. Like, can we hang out and talk about this? I mean, that's basically how this happened, was one or the other of us like sucked somebody else in.
We have a new dean coming, and so I'm hoping to suck him into the orbit when he when he shows up.
We had some good dean support early on in our initial, and then we got a new dean who we were able to get some grant money from. And the other thing I'll say on the faculty side is, it's always a workload question, right? And
yes.
Is it service? Is it scholarship? Are those things even in the workload, or is that just expected above and beyond your 60-hour work week? So I know for me, when I initially started doing it, working with our group, it wasn't anywhere on my workload. It wasn't being acknowledged. It was just extra. And along the way, especially when we formalized running it at our clinic, I went to my chair and I said, I'm going to do this. This is important, and it needs to be in my workload. And she honored that and was able to put it in. And it didn't necessarily take a lot else off of my workload, but at least I felt like then it was acknowledged. It was on paper somewhere. So for other faculty to find that mechanism to advocate with their chair, and again, it may not mean something else comes off, but for it at least be recognized and sort of formalized in that way. It just felt better to me. It didn't make it easier, but it felt better that I knew, at least it was in my chair's awareness that I was doing this work, and it was able to be recognized. And then I was able to fold it in with other like scholarship and service roles.
It's what I'm starting to do now, is that because it was just extra, like you said, me and I had students that would help, and we're trying to figure out, one, how to integrate it with classroom work, because we don't have the patient load yet to really make it something that we can count on for our classroom work. But now it's just started to become one of my administrative duties. So it's on my workload, and again, nothing else came off. But I'm just kind of stuck, I guess, at the moment, to try to figure out how to pull more people in, because we have this beautiful space for the clinic, and to be able to bring patients in. There's parking, there's like everything you would want in a space is here. There's a kitchen, there's a shower, there's a PT clinic, there's counseling rooms. It's a beautiful space, and I'm just trying to, I don't know, just pull more people in. That's where
Do you have access to a health educator?
I don't know if the nursing department has one. We're a very small school, so we don't have a lot of, I don't know if you'd call it like extra departments. We have PT, OT, nurse, we have all of those. We do have a research and assessment, but I don't think we don't have anything. Yeah.
Health educators like to do lovely things like teach healthy cooking classes. And you mentioned a kitchen, and nothing brings people like food.
Yeah, well, that's what we did as part of the arthritis program that I ran. Is we actually, before COVID, the first time I ran it, we cooked a meal together using adaptive equipment. It was anti-inflammatory ingredients, and it was just fun. And so, yeah, that's a thought.
I also don't. I like transparency and honesty, so I want to share with you that we mentioned our clinic that we ran at our college, and we had much of the same things: wonderful spaces, a PT lab, music therapy studio that I got to practice out of, all these wonderful things. And that I won't get into all the reasons why, nor do I necessarily know all the reasons why, but our clinic no longer exists. So there are challenges that we've gone through as well. And the clinic shut down, and that was where we ran the program, and we took it upon ourselves to continue our work. So, I don't want to make it seem like things are all roses over here either, because I know it's validating to hear other struggles too. So we have certainly struggled with some of the same things you're talking about, and continue to.
Absolutely. Thanks everybody for joining us today. What a great conversation. Thanks to the Atlas Pain team for joining us. Have a great holiday.
Thanks everyone.
Thank you.
Thank you everybody.